Hello doctors, today we are here with another very important topic for practical exams, that is X-ray. In practical exams, two type of X-rays are given, either plain or straight X-rays or with some contrast X-rays. The plain X-rays are taken without administration of any contrast material. When a plain X-ray is desired, that you describe the region including the X-ray. Example, you will describe like this is a plain X-ray of abdomen with lower part of the chest or upper part of the pelvis and showing and describe the abnormality. So first we will start with a straight X-ray of the chest and abdomen and free gas under diaphragm. This is the most commonly asked X-ray in the exam for both UG undergraduate students giving general surgery exam or postgraduate resident students that are giving general surgery exams. So this here in the X-ray you can see first you have to describe this X-ray like this is a straight X-ray of the chest along with the upper part of the abdomen showing the free gas under both the domes of the diaphragm, and there is a ground glass appearance in the abdomen. So this is the right border of the heart, this is the left border of the heart, and this is the left dome of the diaphragm. This is the left dome of the diaphragm and this is the right dome of the diaphragm, and below the left dome of the diaphragm there is a free gas under the left dome of the diaphragm, and there is a ground glass appearance. Ground glass appearance means there is fluid along in the abdomen which causes a ground glass appearance in the abdomen, and there is a free gas under the right dome of the diaphragm, and this is the upper border of the liver. This is the upper border of the liver, and there is a air fluid level. This is a fluid level. Here you can see a fluid level. So you will describe this X-ray as this is a straight X-ray of chest along with the upper part of the abdomen showing a free gas under both the dome of the diaphragm, and there is a ground glass appearance in the abdomen. This is another X-ray. You can see here also. Here we can see a huge amount of free gas in under both the dome of the diaphragm. And this is the right dome of the diaphragm and this is the left dome of the diaphragm. What is this radiological appearance? This is, you will say this is an appearance due to a free gas or fluid in the peritoneal cavity. Now what causes this such X-ray appearances? Most common cause of such X-ray appearance is the hollow viscous containing gas because of the hollow viscous perforation, and most common hollow viscous perforation is due to peptic ulcer disease and most commonly duodenal ulcer more than the gastric ulcer. Or other causes, if you are asked about the other causes, then you will say perforation of the malignant gastric ulcer or small gut perforation, large gut perforation. There might be a penetrating injury or bullet injury to the abdomen, or following a laparoscopic procedure there might be gas under diaphragm, or due to tubal insufflation test or tubal patency test also there is sometimes gas under diaphragm. You can be also asked about that whether you will find free gas under diaphragm in appendicular perforation, but the answer will be no. Generally we do not find free gas under diaphragm in appendicular perforation, so therefore in this example appendicular perforation is not mentioned. Now, what are the stages of peritonitis? As you know, this is when there is perforation peritonitis. Because of that, there will be peritonitis, and it is very commonly asked what are the stages of the perforation peritonitis. So there are three stages. Remember, there are three stages of perforation peritonitis. One is the stage of chemical peritonitis. Second is the stage of illusion or stage of peritoneal reaction, and third is the stage of bacterial peritonitis. So starting with the chemical peritonitis occurs immediately and lasts about 2 to 4 hours. It occurs because the gastric content escape into the peritoneal cavity. This results into chemical peritonitis. There will be features of shock, tachycardia and hypotension in cases of chemical peritonitis. And there will be obliteration of liver dullness. When we do percussion, like here, when we do percussion in the right side, if it is a normal one, then there will be dullness note present in the liver while percussion. But in cases of perforation peritonitis, there will be obliteration of liver dullness, means there will be tympanic note while percussing this area over the right side. So this is known as obliteration of liver dullness, which is seen in perforation peritonitis. Now second stage is stage of illusion, means you will think in this case there is decrease in pain of the patient. Why? Because as there is the gastric content is coming out from the perforation side, our body secretes peritoneal fluid to dilute the irritant. So excess amount of peritoneal fluid is released to dilute the chemical irritant. So during this phase, there will be pain will be diminished in the patient, but all the signs will be present. All other signs like tachycardia will be present, hypotension will be present, and dehydration will also be present. And there will be generalized tenderness all over the abdomen. And now number third is bacterial peritonitis. This is a stage of abdominal distension. Peritoneal cavity is next invaded by gut flora and leads to bacterial peritonitis. And there will be paralytic ileus. Patient will be very critically ill, toxic and dehydrated, and septicemic shock and rapid feeble pulse and cold extremity and shallow respiration and hypotension. And abdomen will be distended and generalized tenderness will be present, and bowel sound will be absent in stage of bacterial peritonitis. So 3 stages of peritonitis are very important. Number 1 is the chemical peritonitis. Number 2 is the stage of ileustion or stage of peritoneal reaction. And number 3 is the bacterial peritonitis. Fine. Now we will see an X-ray, plain X-ray of multiple air fluid level. Here we can see this is a straight X-ray of abdomen with lower part of the chest and upper part of the pelvis taken in an erect posture showing multiple air fluid levels. The distended gut loops are situated in the central part of the abdomen and are arranged in a step ladder fashion. These are arranged in a step ladder fashion. The upper loops are showing presence of valvulae conniventis, which are closely packed and complete, suggesting that these distended loops are jejunal loops. In jejunum, you can see these are the distended loops and these are the valvulae conventis. Means this black line have in between them white lines are present. These white lines are present and these white lines are complete. In jejunum, these white lines are complete. In ileum, these white lines are not complete. The distended gut loops in the iliac fossa region do not show presence of any valvulae conventis and appears as characterless ileum. So in this case, why this is a jejunal loop? This is a jejunal loop because the bowel is centrally located, number 1, and number 2, there is complete valvulae conventis. These are the valvulae conventis, these are the distended loops, and these are the multiple air fluid level. And this is a distended ileal loop in the distal portion. And here also we can see the similar portion. We can see a dilated jejunal loop, valvulae conventis, and multiple air fluid level can also be seen in this. So this is likely to be an X-ray of a patient with small bowel obstruction. This will be your diagnosis. Why do you say this is a jejunal loop? I have already told you, because it is centrally located, step ladder pattern, and valvulae conventis indicates white line are closely packed with each other and valvulae conventis are complete. And what are the characteristics of an ileal loop? If it was an ileal loop, ileum will also be centrally located, but there will be absent valvulae conventis or there will be incomplete valvulae conventis will be present. And the gas filled in the loops are typically described as characterless. Now, what in cases of obstruction, there are 4 main features. This you have to remember. 4 main features are present. Number 1 is pain. Number 2 is distension. Number 3 is constipation or obstipation. Number 4 is vomiting. These are the 4 signs of obstruction in a patient. One thing you also have to know is what is closed loop volvulus. Closed loop volvulus is, it is a kind of a bowel obstruction where a segment of intestine twists on itself, causing 2 points of obstruction and locating the loop. Like because of this twisting, there is volvulus, and this is known as closed volvulus. And this closed volvulus can cause strangulation. What do you mean by strangulation? Strangulation means there will be hampering of blood supply. There will be hampering of blood supply, which will cause strangulation, and this can occur in cases of closed loop obstruction. Another thing which is most commonly asked, like there are multiple air fluid level. One thing you should remember, normally in adult, less than equal to 3 air fluid level are present. Less than 3 air fluid level are present normally. And in cases of neonate or children, in cases of neonate, 2 to 4 air fluid level is normal. Fine. So remember this. Not always show. If you see only one air fluid level, it doesn't mean a small bowel obstruction. For you have to see multiple air fluid level which is more than 3, and in cases of child it will be more than 4. And what are the important causes of small bowel obstruction? Small bowel obstruction, this obstruction can be because of like inflammatory bowel disease like Crohn's disease or ulcerative colitis, or it might be due to stricture, it might be due to neoplastic lesion, or it may be due to lumen obstruction. Either there is a lumen and it gets obstructed due to Bejoar's, or it can there might be gallstones. In gallstone, remember, we have the Wriggler's triad. We find Wriggler's triad in gallstone. Wriggler's triad contains small bowel obstruction, gallstone, and pneumobilia. That is Wriggler's triad present in gallstone ileus. Or there might be adhesions or bands, or there might be hernias, internal volvulus, or intussusception. These are the causes of small bowel obstruction. Now we will see sigmoid volvulus. This is also very commonly asked. Coffee bean sign is seen in sigmoid volvulus. So how will you describe this? So this is a straight X-ray of abdomen along with the upper part of the pelvis taken in an erect posture, showing a hugely dilated large gut loop extending from the pelvis to the upper abdomen. The two loops are distinctly seen with outer borders and an intervening wall formed by the inner wall of the sigmoid colon. All these distended gut walls are seen covering towards the pelvis. This appearance suggestive of a large bowel obstruction and most probably due to sigmoid volvulus. So this X-ray is typically appearance of the sigmoid volvulus. The thing which is very next question will be, what do you mean by Dahl-Frontman sign? So what is the Dahl-Frontman sign? There is Dahl-Frontman sign means there will be 3 distinct lines, and these 3 distinct lines will converge in pelvis. 2 lines of outer border of the sigmoid colon and 2 inner wall which will form an intervening line. I will explain you this. What is Dahl-Frontman? This is the one line. Fine, this is the one line. This is the second line. These 2 lines are due to the outer border of the sigmoid. And this inner one, this is the inner lining, and this is also the inner lining. This is an intervening line, and these all 3 lines, this line, and this line, converge towards the pelvis. So these 3 lines when converge, it is known as Dahl-Frontman sign, which is seen in sigmoid volvulus, and this classical sign is known as coffee bean sign. This classical sign is known as coffee bean sign. And what is volvulus? Volvulus is an abnormal rotation of a segment of bowel around its narrow mesentery, causing obstruction of its lumen and may subsequently lead to strangulation or gangrene. Strangulation means there will hamper in the blood supply. And what are the sites that cause volvulus? One, you know, this is in sigmoid volvulus. And remember, very commonly asked, in sigmoid volvulus, there will be anti-clockwise rotation of the sigmoid. So this will cause sigmoid volvulus. In cecum, there will be clockwise rotation. Remember, C for cecum, C for clockwise rotation. Apart from that, there might be volvulus of transverse colon, small intestine, or stomach. In stomach, remember, there might be 2 types of volvulus in stomach. One is organoaxial and one is the mesenteroaxial. In mesenteroaxial, the stomach rotates in between this line. This is the midpoint of lesser curvature, and this is the midpoint of the greater curvature. When the stomach rotates around it, then it causes mesenteroaxial, and if the stomach rotates around the long axis, then there is an organoaxial. These 2 names are also asked in the exam, mostly important for postgraduate general surgery students. Now we will see radiopaque gallstone or kidney stones. So as you can see here, this is a plain X-ray of abdomen with upper part of the pelvis showing multiple radio-opaque shadow in the right paravertebral region below 12th rib. This is the right paravertebral region below the 12th rib, and which appears closely packed. Apart from these, there is another dense staghorn type of radio-opaque shadow in the right kidney region. So this appearance is radio-opaque. This may be gallstone or a kidney stone. So next question will be, how will you differentiate whether it is a gallstone or this is a kidney stone? So remember, to confirm the diagnosis, we will take a lateral view. Remember, the gallstone is anterior to the vertebral body and the kidney stone are posterior to the vertebral body or it overlaps the vertebral body. This is how you will confirm whether it is a gallstone or it is a kidney stone. And remember, 10% of gallstone are only radio opaque, but 90% of the kidney stones are radio opaque. And what are the differential diagnosis of this? This X-ray, differential diagnosis of this X-ray, this may be a kidney stone, gallstone, pancreatic calculi, foreign body, fecalith, or calcified lymph node, or calcified renal tuberculosis, calcified adrenal gland, or chip fracture of the transverse process of the vertebra, or calcification of the costal cartilage. These are the differential diagnosis of the radio opaque shadow in this region. Remember this, very commonly asked. Another question which is very commonly asked, what are the type of renal stones which are radio opaque? Like radio opaque means you will see this white color. So these are the oxalate stone, phosphate, cystine and xanthine stone. And what are the stone that are radiolucent? That is, one is uric acid stone, another one is urate stone. These two stone, kidney stone, are radiolucent. You cannot see in X-ray. So now we have another X-ray here. This is an plain X-ray of kidney, ureter and bladder. And here you can see a radio opaque shadow in the right half of the pelvis. And this is mostly because of the bladder stone. This is how a bladder stone look like. Now we will start with an important thing, that is barium swallow meal, barium meal follow through and barium enema. First, starting with the barium swallow X-ray. Here you can see a barium swallow X-ray of achalasia cardia. So why achalasia cardia? Because this is a smooth margin. There is no irregularity present. This is smooth margin. This margin is smooth. And this is known as bird beak appearance. This is known as bird beak appearance seen in achalasia cardia. So this is the shadow of the heart. This is the dilated segment of the esophagus. Here the white thing, this is the dilated segment of the esophagus. And this is a smooth pencil shaped narrowing. Smooth. This is a smooth pencil shaped narrowing. There is no irregularity present. Here also you can see site of normal narrowing due to compression of the aortic arch. So this is a barium swallow, not barium meal. Remember, barium swallow of esophagus. Why do you say this is a achalasia cardia, not carcinoma? As I have told, this because of the narrowing is smooth. No irregularity is present. Therefore, this is an achalasia cardia. What is achalasia cardia? Achalasia cardia is a condition of failure of lower esophageal sphincter to relax due to loss of ganglion cells in the myenteric plexus of the esophagus. And the investigation of choice in achalasia cardia is manometry. Remember, the investigation of choice is manometry. And treatment might be asked to you. First, we will start the medical management with calcium channel blockers and nitrate. And apart from that, there are many advanced treatment for achalasia cardia, like POEM is present. Per oral endoscopic management of achalasia cardia. Sometimes we do Haller's myotomy also. If you are asked about the drug of achalasia cardia, calcium channel blocker like nifedipine is useful to relieve the symptoms in achalasia cardia, but it used in long term is not so effective. Therefore, there might be role of dilatation also. We can do endoscopic dilatation also in cases of achalasia cardia. We can give botulinum toxin also in management of the achalasia cardia. Now we have the barium swallow of carcinoma of esophagus. Here we can see an irregularity present. Here also this is irregularity present. There is a dilated this, and this is narrowing of the mid-esophageal segment, and this is a dilated proximal esophagus and narrowing of the esophageal gastroesophageal junction, and this is the stomach. So this is a you can describe this like this skygram of barium swallow X-ray of esophagus showing irregularity feeling at the mid esophagus. There is that dilatation of the proximal esophagus proximal to the site of narrowing. This appearance is suggestive of mid esophageal carcinoma of esophagus. So what are the usual presentation of carcinoma of esophagus? In a patient of carcinoma esophagus will present to you with regurgitation of food. There will be regurgitation of food. Apart from there will be weight loss. In cases of carcinoma, there will be cough. There will be present of anorexia in carcinoma. And there will be, you can find neck nodules, neck mass due to lymph nodes in the neck. There will be hematemesis, and there will be presence of melena in cases of carcinoma of esophagus. How will you confirm this diagnosis? You will confirm this diagnosis by doing an upper GI endoscopy, and you will take biopsy from the lesion, will confirm your diagnosis. And you have to also remember the TNM staging of esophagus. For you can be asked if you get an X-ray of this, And what are the predisposing factor of carcinoma esophagus? Like dietary food, like pickled vegetables, salted dry fish, smoking, chronic alcohol intake. Barrett's esophagus causes adenocarcinoma of esophagus, or stricture of esophagus. Achalasia cardia causes squamous cell carcinoma of esophagus. Then chronic esophagitis or hereditary tylosis is a risk factor for carcinoma of esophagus. Now we have an barium meal X-ray. We have completed barium swallow. Now we will see barium meal. So this is a skydiagram of barium meal X-ray of stomach and duodenum. The stomach is seen normal. The duodenal cap is not well formed, and there is an ulcer created at the region of the duodenal cap. This appearance is suggestive of deformed duodenal bulb due to chronic duodenal ulcer. We can see here a deformed duodenal bulb. This is a deformed duodenal bulb. Here also there is a deformed duodenal bulb. So this may be because of the duodenal ulcer. And here also we have a barium meal X-ray of chronic gastric ulcer. Here you can see, in this you can see complete white color is present. But here you can see there is a white color as well as there is a black color present. This black color is because of air. And this is known as double contrast barium meal. What do you mean by double contrast? Double contrast means two things, two contrasts are given, and this is most commonly asked in exam also. What do you mean by the double contrast? If you see white along with the blackish color, this means this is a double contrast. And how do you do, how a double contrast in barium X-ray stomach and duodenum is done? First, injection Buscopan is given to the patient to delay the gastric emptying of the patient. Then we give a tablet that is composed of calcium carbonate. When the patient takes calcium carbonate, after few times there is release of carbon dioxide in the stomach, and when there is release of carbon dioxide, after that we inject 150 to 200 ml of high density of barium, and then we take the X-ray. Then we will find this double contrast X-ray. If you get only white color throughout below, then this is a single contrast. If there is an air in between the white color, then this is a double contrast barium meal. And this is a benign gastric ulcer. This is why benign gastric ulcer, not malignant, because this is present over the lesser curvature. If there is an ulcer which is present in the lesser curvature, most probably this is a benign gastric ulcer, and it projects beyond the lumen of the stomach. It projects beyond the lumen of the stomach, which also characteristic of a benign gastric ulcer. In barium meal X-ray of the carcinoma of stomach, this is a barium meal X-ray of a carcinoma of stomach. Irregular filling you can see here. There is an irregular filling. There is no contrast in between this. So there is an irregular filling defect at the pyloric region of the stomach. And there is shouldering contrast material along the greater curvature. Here you can see a shouldering. Here you can see shouldering material is present, and there is an irregularity present. This is the greater curvature of stomach, and this is the lesser curvature of stomach. The radiological characteristic, why this is a carcinoma stomach? Because this is a mass lesion. Margin of the mass may exhibit a shouldering. This is the shouldering effect. As you know, this is a shouldering effect, and forms an acute angle with the gastric wall and the pyloric antral region. In the antral region, if there is a lesion present and shouldering is also present, then this is a carcinoma, a malignant condition, not a benign condition. And in case of lesion present or ulcer present in the lesser curvature of the stomach and projects beyond the lumen of the stomach, then that is most probably a benign condition. Now we will see barium meal follow through of an ileocecal tuberculosis. So as you can see, this is an dilated ileum. This is the dilated ileum proximal to the site of. Why ileum? Because ileum is characterless. There is no volvulae conventus. And here this is the colon, because in colon we can see the haustration. This is the transverse colon and this is the ascending colon, and this part is the deformed contracted part near the ileocecal junction. Narrowed ileum is present, and in cases of tuberculosis, there generally the cecum is pulled up. Cecum is pulled up, and in cases of tuberculosis, there will be features of night sweats. Night sweats is also present in cases of lymphoma. Remember, in this both condition there is presence of night sweats, but in cases of lymphoma there will be lymph nodes in other parts of the body also. But in cases of TB, there will be no lymph nodes in the other parts of the body. This is how you can differentiate between a tuberculosis and lymphoma. So this is a skydiagram of barium meal follow through. Barium meal follow through means this: you have drank the barium, it have passed from the esophagus to stomach to small intestine. Now it have reached the lower part of the small intestine and the large intestine. And this X-ray is generally taken after 6 to 8 hours of barium intake. So this X-ray is taken 8 hours after the ingestion of the barium. So this is a case of ileocecal tuberculosis, where a structural lesion is present. You have to know the types of ileocecal tuberculosis. It may be ulcerative type. Ileocecal tuberculosis can be ulcerative type, or it can be an hyperplastic type. In ulcerative type, malignant tubercular ulcer develops in the terminal ileum mostly, and in hyperplastic type, it is due to ingestion of the mycobacterium with high resistance to organism. There is hyperplasia of lymphoid follicle in hyperplastic type. And this patient will present to you with recurrent attack of lower abdominal pain, diarrhea, weight loss, anemia, fever, and mass in the right iliac fossa may be present, and subacute intestinal obstruction. Features of subacute intestinal obstruction will be present in this patient. Now we have X-ray of barium enema of carcinoma colon. Here we can see this is the right side and this is the left side. Stenosis in the lesion is seen here. Here we have given enema. Enema means we have given the contrast via the anal opening. So it has traveled from the anorectal canal to the descending colon, transverse colon, then ascending colon. And while traveling through the ascending colon, there is a stenosis found here. Fine. And here you can see better. In this, you will see an apple core deformity in cases of carcinoma colon in barium enema. So this is the skygram of, this is also a double contrast enema. You can see an air here, double contrast enema, where the normal hostrations and the filling of the sigmoid and descending colon and abrupt narrowing of the right colic flexure and fine streak of the barium is seen going through the ascending colon. And this appearance is suggestive of stenotic lesion in the right colon flexure. So this is a case of a carcinoma colon. And what are the other possibilities of stenotic lesion? Why other stenosis may be present apart from carcinoma? Because of tuberculosis, as I have shown previously. Apart from that, Crohn's disease, ischemic colitis, radiation enteritis, carcinoid tumor, lymphoma, or anastomotic stricture. How will you prepare a patient for barium enema examination? This is also very important and asked. First, you will ask the patient to have a liquid diet 24 hours before the date of the examination. You will tell the patient to have only liquid diet. Then you will give 2 consecutive night before 2 consecutive night you will give purgatives, so that there will be easily motion will be passed and patient's stomach will be quite empty. And night before the examination you will give enema to the patient. So 3 things you have to do. First, you have to give liquid diet for 24 hours. 2 consecutive night you have to give purgative, and then you have to give enema the night before the examination. This is barium enema. Now how will you do the double contrast in cases of barium enema? You have know in cases of stomach we give the tablet of calcium carbonate to release carbon dioxide to have a double contrast. But in cases of enema, how will you do the double contrast barium? In this case, you have to do 3 things. First, feeling of the barium, then gas insufflation, then radiography. First, Vascopan is given in that case of stomach. Also barium will also you give the Buscopan. Here also you will give a Buscopan to delay the emptying. Then we will give a barium suspension, is given through the rectum. Then we insufflate air. Carbon dioxide gas is generally used to insufflate gently to move the barium colon. And then by turning the patient to the left side up and head up, the barium column is pushed to the right half of the colon. First, we will move, left side will be up and head will be up, and the barium from the rectum is then partially drained out. Serial radiographs are taken in different position, and via this we can visualize the anatomy of the colon, that is large gut and rectum and anal canal also. So this is a case of barium enema. And remember also one thing, we have the right colon, transverse colon, and then the left colon. And remember, in left colon cancer is more having stricturous lesion, and in right colon cancer the patient generally presents with bleeding. Why stricture? This is commonly asked. Why stricture is more common over the left side? Because the diameter of left colon is smaller than the diameter of the right colon. The diameter of the right colon is more than the diameter of the left colon. So the most stricturous lesion is seen over the left side and more bleeding features are seen over the right side of the colon. Fine. So in the next part, we will continue with the part 2 of the x-ray. Thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for all the medical students out there. Thank you, guys.